program by, for, and about women today with Sandra Elkin.
Good evening and welcome to Woman. Tonight we're going to continue our discussion of the nursing profession. With me is Dr. June Rothberg. Dr. Rothberg is Dean of the School of Nursing at Adelphi University. She is immediate past president of the American Association of Colleges of Nursing. She is co-founder of NCAP, the Nurses Coalition for Action in Politics. Also with us is Dr. Jean Spero. Dr. Spero is Dean of the School of Nursing at the State University of New York at Buffalo. She is Chairwoman of the Board of Review of Baccalaureate and Higher Degree Programs of the National League for Nursing. Also with us is Dr. Joanne Ashley, author of Hospitals, Paternalism, and the Role of the Nurse. Dr. Ashley is an Associate Professor of Nursing at Northern Illinois University. She is on the Board of Trustees of NCAP. Welcome to all three of you once again.
Thank you.
Now, last week, Joanne said some very strong things about physicians and the system under which nurses work. And I got the strong impression at the time that you would like to say something further on that subject, and you probably better do it now.
Okay. Well, one thing I'd really like to add to that is Joanne was concentrating on physicians, and I think we didn't really talk enough about the system. It's a large, complex system. It vastly needs overhauling, but I don't think physicians are the only culprits in the system. I think hospital administration has been a problem. I think the whole concept of the delivery of health care has been a problem, and so that I think it's rather unfair to focus on one aspect of the system. I think nurses themselves have contributed to the difficulties in the system, and currently we're trying to get nurses moving to do their thing, if you will, to get the system straightened out.
You're not saying that doctors are not the problem, not the whole problem. You're saying they are not the whole problem, they're just part of the problem.
That's right.
And I think that I would follow through with that too, because I think if you talk about health care, you have to really think in terms of a total system approach. And this includes the relationships between physicians, nurses, allied health professionals, and, you know, the hospital administrators, and the way in which they plan together for what could conceivably be a better healthcare delivery system.
But is it not true that nurses really don't have at this point much of a voice in the power structure?
Sandy, it is very true. They have almost no voice at all. Now, both my colleagues June and Jean have done one thing that nurses have done for a century. Go all out to be fair to a group that for a century has walked on them, beat them down.
Okay, give us some facts. Some of the things in your book, for instance, about the early history of the oppression of nurses.
Well, prior to the second decade of the century, they worked 12, 16 hours a day in hospitals. And they, you know, that was the way it was done. It was in California around 1913 that good-hearted citizens, not nurses, public citizens, women, said, look, those nursing students are just treated like animals. You know, they shouldn't be worked like workhorses. So they went to the legislators and said, listen, let's get protective laws to protect women, give them require hospitals, which were defined as continuous industries, to only work these poor women 8 hours a day. You see, men, dominant, did not respect women enough to say, look, we're overworking you. It's poor for your health. Besides, those nurses worked that long were dangerous to the health of patients. If you worked for 16 hours, and I did it in 61, by the way, we would work as students all day, and then they'd run out of somebody in the hospital. A nurse wouldn't come in because she's probably home in bed resting. And they'd call us, and we'd work 16 hours. I've done it myself.
Wait a minute, she'd be home in bed resting.
She needed a rest.
You mean from working all day?
Running.
Okay.
Running, serving doctors.
I don't want to have both the nurses and the doctors on our net.
Well, you know, really.
I think I can't help it, Joanne. You know, I said before, and I'll say it again, I think you're painting one or two groups totally black, and you're painting nursing totally white.
Well, now, we're black, too. I'd rather have nurses wear black uniforms than white ones. White means purity, innocence. You only grow as a human if you go down a little few dark paths. Darkness. I see black a lot. I really do.
There has been a real Victorian attitude toward the nurse and the morality of a nurse, hasn't there?
Yes.
Yes, and I think Joanne's book, you know, I think, as June has said repeatedly, that there is much in her book that is of great value, because in her book she does write very succinctly about the historical evolution of nursing, and points out, I think, very, very clearly why we are where we are today. And it does tie up with male-female relationships and apprenticeship systems, you know, types of education.
Well, you look
but I
at,
think we're moving away from it.
but you look at how we're educated to behave pure, innocent women in white in the hospital. But then look,
Still, I mean, right now.
Still-
No.
well, no, that
No.
when people are socialized, they don't get over it overnight. Okay? I was born and reared and raised in nursing to believe that. But you look at how we're portrayed in the movies. We're witches, bitches, whores. We're
Women or
sexual
nurses are you talking about?
Well, very often nurses when they appear in a movie. So you see, I have had to ask myself, what in the world does society expect of nurses? They want this saint over here, and they want this sinner over here. This immoral character. I'm tired of it. I am tired of it. And as I said on our other program, I am at this point, I don't care whether anyone believes me or not. It's their health that's in danger.
All right, let's talk about what you claim is the damage that's been done
Okay.
to the public by the American healthcare system, and let's be very specific about that. And I think June and Jean also agree that there's been damage. So someone tell me specifically what's been done to me and everybody else by the fact that nurses have been oppressed and by the fact that our healthcare system is not what it should be.
Well, maybe, you know, June, you can help me a wee bit with this. I think, and this was said on our last program, that there is much more that nurses can do in the practice of nursing than they are currently legally permitted to do. I think that this kind of restraint deprives the public of the full impact of total nursing care. Some of the other things would have to do with the ratio of professionally prepared nurses in hospital institutions.
So you're asking for legislation then, really?
Well, no, I'm not asking for legislation at this particular point in time. If you're talking about, you know, who is a professionally prepared nurse and what kind of educational preparation. No, that's another side issue. I think what I'm talking about is if you look at the manpower within a hospital, an acute care facility, as an example and point, and you assess what the needs of the patients are in that kind of facility, we should be able to make a very clear determination of the ratio of professionally prepared nurses to non-professionally prepared nurses, practical nurses, and aides. And at this particular point in time, I think because of the economics of the situation, very often this ratio is reversed from what it should be. And there are probably more non-professionally prepared nurses staffing the wards and the institution than there should be in relation to patient care needs.
Is it because they get lower salaries?
Well, nursing salaries are not good. They're abominable in places, and in other places they are coming along very, very nicely. I think there are several things going on. One is the issue of education, and when Jean talks about a professionally prepared nurse, she's talking about someone with a baccalaureate or higher degree. 81% of all nurses have not acquired that level yet. There's a rising curve, as I said in our last program. More and more people are going into baccalaureate and master's education. Right now, something like 3.3% of the million nurses who hold licenses in this country hold master's degrees. Something like around 14% hold bachelor's degrees.
Let us emphasize that's the effects of oppression.
That is quite true. But more and more people are going into these programs, and as they are being produced, the more advanced institutions, and let me point out that nursing is practiced in a lot of places other than hospitals.
Right.
But where I come from, for instance, more and more of the hospitals are moving to hiring baccalaureate prepared nurses for their staffs. They're going into new modes of nursing care, primary care, in which a nurse is responsible for a very small group of patients, and she's responsible for those patients on a 24-hour basis, regardless of whether she is there or not. And she plans for their nursing care. And it's a very different kind of nursing than the fragmentary parade of individuals. Housekeepers, aides, practical nurses, professional nurses, interns, residents, x-ray technicians, anybody else. A million people go in.
June, I think we ought to pick up on one point you made,
Yeah.
that nurses do not only work in hospitals. Nurses are in every, and this is historical fact, currently true, they're in almost every social institution that this country has got. They work everywhere.
Let's see, they're in schools, they're in
They're
factories.
in industries, the armed forces. So it's logical for society to begin to think, now if we get qualified nurses who really are giving health care, nursing care, we're going to improve health care. In industry, for example, and I have two real live sisters, not sister in the feminist sense, who work in industry. Their role is just as narrow. They serve the physician and others there, just like they do in hospitals. Now, in other settings, nurses are more free. You know, nurses like to work in the community, for example. Public health nurses, they have freedom. But we are everywhere, and if some money could be invested in us and in our development, we'd have quality care. We won't have it until this is done.
Let me ask you a question about primary health care service by a nurse. Would this free the nurse from the myth of being supervised all the time?
Oh,
Would
yes.
she then, in that situation, be free to make decisions and carry through on
Yes.
patient care?
That's a myth, by the way, that
Okay.
nurses are supervised. You know what nurses really do? They supervise the physician's work. They very often do his work, and he gets credit for it, he gets paid for it. The nurse is there doing it. She supervises medical care. She's there. You just look and see. Look around. See how many doctors you see in a hospital supervising care. The nurse does it. That's a myth. It's also legalized, by the way. Legally, the nurse has always been under the doctor. It should be the other way around. He should be under her, legally, if we're really going to protect the public.
I can't imagine that ever happening.
I
And
can.
also
I
legally,
can.
I'm not sure what you mean by being under either, because at least in the New York State Nurse Practice Act, there is nothing that says
Well,
that the
our-
nurse is supervised by the physician.
Our nurse, no, that's
Is that something new?
No.
No.
That's a
No.
myth, though. No, it does, too. Legally, nurses, we're just moving into a decade where in the various states, nurses are changing their nurse practice acts. Now, that again is in my book. Nurses got laws passed. You know, they wanted to be like doctors, like dentists. They wanted to be legally recognized, legally protected. So they got these laws passed well before women got the vote, which was about 1920, I think. But at that time, men were superior, dominant. This was written into the laws. It simply recognized what already existed. Now, we are just in this decade beginning to change those laws, and it's a hassle, you know, because physicians don't want to change. They don't want this person to be free to give health care, to give nursing care. They want, and that's for economic reasons, by the way.
Only?
Not only, it's tied in with myths, which have to do with, you know, really they influence people's behavior and you don't know you're being influenced by it. But basically, it's economic. So long as they can control this person, you know, and keep her in her place, they can hog all the money and not share it.
June, you wanted to say something a minute ago.
Well, I wanted to say several things, and I wanted to say something in relation to your comment about primary care, which I think people are treating as if it's a new kind of concept
I
on the
misinterpret it?
horizon. Well, again, I think it deals very much with your definition, but as a public health nurse of many, many, many years before I went into education and administration,
You were doing
we were
primary
doing
care.
primary care, and we were making decisions, and we were treating the total family, and we were doing health promotion and disease prevention, as well as all of the other usual kinds of things that one thinks of in terms of nursing.
But not in a hospital, though, right? Is that the
No,
difference?
public health was in the community. I had my little bag, and I went out and I went to families in their homes and did all kinds of
Do
interesting
you think
things.
nurses, Jean, if they were paid, let's say, an honest income like 20,000, we could say 50,000, or like some of the New York doctors, 250,000 a year, and we put enough of them on the streets of New York City,
I wish you'd use a different expression.
or
but-
in rural areas, we'd have quality care, really, functioning as you did as a good old-fashioned public health nurse.
Well, you see, I guess it's you know, we're not talking about a good old-fashioned public
I
health
am.
nurse.
I want
No,
one
I
if
think
I
we're
ever get
talking
sick.
about public health nursing. I think it is practiced that way now. I think it is probably even improved over the time that I was practicing it, because I think that the nurses that are doing public health nursing, at least again in New York State, they are required in order to be a public health nurse to have a baccalaureate degree. So I think the kind of public health nursing that they're doing
This gives
is
me an opportunity.
probably much better because of
But
the broader
Jean,
educational base.
Let's look at reality. For example, when I was in Kentucky doing my public health experience as a student, I went with the public health nurse because we were supervised. You know, you do on the job. This woman was so broken-hearted by what she saw in and around Louisville, Kentucky, where starvation. Now, she had a heart. Now, she took her paycheck, really, and bought food for those kids. They had pot bellies. They were dying of starvation because she couldn't stand it, and her husband made her quit it. Now, you see, if people would just open their eyes, they can see horrible sights on the streets of our cities, in rural communities.
Yes.
People, you know, this
Joanne?
is how the public has been damaged. People aren't getting care. We have health problems that are real. Now, I am no longer going to ignore them. We've got to look at them. Now, I'm saying, for example, I teach in Illinois. There's a small rural community there. Now, there's been so much attention and focus given to medicine. It's been idolized. It's been worshipped. What that rural community needs, they've got about, I don't know how many doctors, let's say 4. And communities get scared when their doctors leave. What a community needs is 4 doctors, 4 professional, let's assume, 4 professional nurses.
By professional, you mean with a degree?
Highly qualified, yes. Yes.
I might even make the
Competent
ratio
nurses.
somewhat different than that. I don't know if
Well,
it
I
should
don't
be
care
4 to
about the
4.
ratio. It would depend on the size of your city.
She's
but I
trying
think,
to-
yes,
she's
but I
trying
think
to
this
be
is
fair.
important because I think this is one of the things that we have to
I am
do
fair,
in
yes.
terms of health care delivery, okay?
Even if you have to be.
I think that we do have to look at in terms of what the needs are in a given community, what the skills are of the people that are delivering the health care, and then the ratio of professionals that are needed in order to do the kind of healthcare delivery that you're talking about. And it may be that you need 3 physicians, general practitioners in a community, and maybe you need 10, 12, or 14 public health nurses
Well,
and, industrial nurses or whatever you
The
want to
public,
talk about.
though, community leaders have got to start recruiting nurses just like they go all out to recruit a doctor.
This is true.
And recruit the best possible nurse.
The
right?
best possible nurse, and make sure of it. Put demands on educational institutions and say,
All right.
we need
Okay,
nurses.
public officials, it seems to me, are not likely to begin doing this tomorrow
right.
or the next
That's
day.
right.
All right, what would have to happen in order for that
Well,
to begin?
They need to be exposed to what nurses can do, have done on a very much broader scale. And Joanne, you talk about a public health nurse in Kentucky spending her own salary, which was very altruistic and very giving and warm and loving. But I also think it was absolutely self-defeating. She would have accomplished a great many more things along with that if she had done something about pressuring the social system to provide
Exactly.
incomes
That's the
into
point.
that, and she needs to know about the possible resources in the community to do this.
That's true, June. You see, I knew her husband was smarter than she was, but he didn't have a heart. See, that's the problem with nurses. Because they care, I mean, she was really a little bit stupid, to starve herself to death maybe, to feed someone else. But then again, there's a principle hidden there. I would have trouble. I had trouble. I saw those little kids myself. I didn't have any money, but I might have given it away.
Well, that's what NCAP is for now, right? Is that the goal?
To make a
You
difference.
mean for political
Yes.
action?
For political
Yes,
action?
Yes.
to organize nurses to become aware of the fact that there is a huge potential among nurses. I mentioned before there are something over 1 million nurses who hold licenses to practice in this country. That's 1 million votes.
That's
Since
right.
1 million,
That's a lot of power.
We could
that's a
elect
lot
the
of
president.
power. Those
We
million
really
nurses have friends and family and patients and clients. Yeah, and regardless of which side of the political spectrum they come down on, they have the potential to influence the outcome of voting. And a group of us back in 1970 began to look at how health legislation was coming about and who was influencing health legislation and what were the perspectives of those people, primarily in Washington, because we were talking principally about federal legislation, but the same thing obtains in the states. We were looking at the kinds of decisions that were being made regarding health care. We looked at the fact that nurses had almost zero input into the decision making. And when we approached our legislators and said, look, we are the largest group of healthcare workers in the nation, and we have some very real contributions to make and some very, very good ideas, and we are very concerned over the issues. We were not heard very well. We were not heard because we were not organized. We were also not heard because we had no financial resources to contribute to campaigns. And that happens to be reality, and there's nothing illegal or dirty or nasty about it.
We had no money because we have been forced to live in poverty as a group of women struggling.
But we also had no money because we never thought that we ought to contribute any money to this. This was completely outside of our socialization again, our sphere of thinking, or many other things. We just did not think in those terms.
Well, it was not within the definition of the role to be
Absolutely
political.
not.
That's right.
Absolutely not.
But I think the point that June is making
Unfeminist.
very well is that it is becoming part of the definition of the role. And I think that's important. I think that this is a very strong component of the educational program for nursing. I cannot speak for all schools, but I can say that it's certainly in the baccalaureate programs. One, helps nurses to deal with how one affects change. What is power? What is the role of women? What is the role of nurses? And when I say nurses, I am talking, I think, in terms of the new nurse, the nurse who is capable of effective decision making and who is capable of affecting change and who knows what's going on out there and realizes what it's all about.
What I think is exciting from my point of view of, talking to you all and doing some research on this is the broad spectrum of political thought that's going on within the profession.
Yes.
I mean, the extremes are wonderful, and the fact that you're all talking to each other and you're all still sitting down with each other makes me think you have a very good chance of doing some of the things that you're interested in doing.
I think this is one of the most exciting times for nurses.
Oh, yes.
It's also, June, you said to me on the phone when we talked in July that it's also the most dangerous time.
Yes, I think so, because of all the pressures and because of all the stirring and because of the realization, which is rising among nurses, that there are so many problems, that they are powerless and they resent it and they refuse to continue to be powerless. And so they are looking at the tools that are available to them to correct the healthcare system to terms that they would like to see it. They would like it to be a healthcare system rather than a sick care system. They would like to have a large influence on the system because they know they have a large contribution to make. So that this surfaces in what Joanne was talking about before, the move to change Nurse Practice Acts, the move to obtain financial supports for new innovative educational programs, the move to produce new kinds of practitioners to deliver a different level of nursing care, and nursing, I underline, not anything else. All of these movements on the part of nursing are naturally being interpreted in very many ways because we're upturning a very placid apple cart, and we are being perceived as a threat. And so when we try to change the Nurse Practice Act to make it relevant to the level of nursing practice of the day, then there is a tremendous amount of opposition. And various groups are discontent with our efforts and are trying to stop us. And I see there's a whole move in nursing to develop nurse practitioners who are doing more than nurses used to do.
June, also at this time, you know, we must not let them stop us this time.
Oh, I don't think that we intend to.
But this involves a little bit more than just focusing narrowly in on to nursing. You know, we've got to contact our politicians and make sure they understand the damage done to the public by this system. And I think they're beginning to with the, you know...
Well, obviously some word of that kind has gotten out. I mean, it certainly reached me. It's reached, you know, people
and also the public. We have to present facts again and discuss it with the public, ask the public to help us.
You know what I worry about?
The public is becoming increasingly aware, I think, of the effects of the current healthcare delivery system.
Sure,
you
the
see,
costs
and I would
are going up and the quality is
tend to
going
say,
down.
okay, one must keep this awareness, you know, in front of the public and in front of all the various, you know, healthcare professionals. But I think we also have to do what June is talking about, and that is move towards planning for how we can help to improve the healthcare delivery system.
Yes.
You know, you can expend so much energy looking at what was that you never get beyond the point of looking at what was in terms of what we can do to make it better.
If you don't look at what was, and if you don't look at history, you'll move forward.
I didn't say that we shouldn't.
I know.
I just
But
said
you
let
see,
us not spend all of our time looking backwards.
To me, that's a priority, because you've got to understand the past before you can move wisely
I agree.
ahead.
And I don't think anybody is debating
Now,
that.
what nurses did as women, and I think possibly women have done this, they struggle so hard to get an education. Not supported, not well financed. So they put all of their energies and their efforts into trying to get into universities. Universities didn't want women, and it was worse to be a nurse, too. So they struggled and had this very narrow goal of getting an education, getting decent schools. Took all of their energy. Plus, they had to beg physicians and others to let them get an education. Now, I'm saying we must totally redirect our energies.
That's it. We're out of time. I thank you all very much. It's been most interesting for me. I thank you for watching, and good night.
This program was produced by WNED-TV, which is solely responsible for its content. Major funding was provided by public television stations. Additional support was provided by unrestricted general program grants from the Corporation for Public Broadcasting and the Ford Foundation.